Dear colleagues and friends, dear students, once again I would like to say thank you again for allowing me to present another research from Melanoma Hospital, or the second case where we have used special diagnostic approaches in order to detect and to follow the rules of the American Joint Committee of Cancer and the European Journal of Cancer for surgical treatment of cutaneous melanoma. Then I would like to present a case of Nevus associated scalp melanoma, which has been treated accordingly surgically. There, all authors declare there is no conflict of interest, and this research did not receive any financial support. We present a young 29 years old lady with congenital monocytic nevus on the scalp, which has been repeatedly irritated in the recent years according to her anamnestic data. During the clinical examination, in the parietal area of the scalp, the presence of pigment lesion with uneven edges and relief surface was found, which clinically dermoscopically was indicative for probable cutaneous malignant melanoma, so that we have taken immediately the decision to make a surgical excision with a narrow surgical margin, as you can see, no more than 0.1, 0.2 centimeter in all directions. And the surgical defect was closed, of course, with single interrupted stitches and really heavy undermining in all directions in order to have this closed. Here you see this. I have performed this in my private clinic, Oncoderma. And after that, we have found that this melanoma with 1.96 millimeter breast tumor thickness, no ulceration. And then we have taken the decision to perform the re-excision and sentinel lymph node biopsy in the Melanoma Hospital. Accordingly, and of course this time we have again performed the dynamic lymphoscintigraphy for sentinel lymph node combined with spexity, and we have the spexity have showed data for 2 sentinel lymphatic nodes which were located adjacent to each other just behind the right parotid gland on the lateral boundary of the musculus sternocleidomastoidus, the larger one having an axial size of 8.07 millimeter. On the later slides of the spexity, 2 additional cervical lymphatic nodes located in the deep lateral cervical lymph chain has been seen right, with the 3 to 4 millimeter size, and 1 lymph node behind the left parotid gland, which has been interpreted as satellite, not sentinel lymphatic nodes. Here you see the injection sites, sentinel lymph node on the left, sentinel lymph nodes on the right, and the injection places and a very good location of these areas. Of course, you know that it's a dangerous area. And here behind the sternocleidomastoidus, here you can see this region on spexity. Together with, of course, Professor Lozef, I have taken to be nearby myself, near me, because of course it's a very difficult location, and small mistakes could have significant consequences when important vessels has been accordingly touched. First of all, we have taken the decision to make eradication of both sentinel lymph nodes on the right, then regular ultrasound control the non-sentinel satellite lymphatic node on the left in order to detect any eventual dynamics of increase or decrease in its size, and a re-excision of the primary tumor area with a 1.5 centimeter all direction. Of course, one day after lymphoscintigraphy, spexity study, the patient was hospitalized for the simultaneously removal of the sentinel lymph nodes and the secondary excision of the primary lesion with an additional surgical security field of 1.5 centimeter in all directions. Then we start here with the careful undermining in the neck area where we have found the first lymphatic nodes. Then you see the vena cephalic interna and externa. And it is a very sensitive area, so that we were very careful. Here you see after detection with the gamma sonde, we have one by one we have removed several lymphatic nodes, which gave a positive signal. And here you see the nevus hypoglossus, vena jugularis down, and vena facialis in the middle of this picture. So that after this removal, we have performed stepwise closure of the first subcutaneous and then cutaneous stitches with drainage. Then we have taken the decision to perform the excision with additional surgical margin of 1.5 centimeter in all directions, so that you see that it's a problematic lesion in the scalp area, because it is the elasticity of this area is already a problem. However, we have performed it and perform additionally the closure with a single interrupted stitches, so that the patient was okay. Here you see it, I think after then 20, the patient is without any complaints. Of course, we gave all these histological materials. There were 12 histological materials which gave some signals, so that we have removed all of them. But there was no metastatic substrate, so that the staging was 1B or T, 2A and 0M0. And once again, we want till nowadays the ladies without any problems in regularly oncodispensary control. And as already mentioned in the previous presentation, there are two steps of melanoma surgery. First, the surgical excision with a narrow surgical margin, as we have done it. In the second step, we have combined it with a secondary re-excision and the sentinel lymphatic nodes. When we know about 1 and 2, we have also to perform 2 surgical sessions. Regarding the rules, it is 1 to 2 centimeter the complete surgical margin within the both surgical session combined with the sentinel lymphatic nodes. And when we have the recommendations with this, you have it here, parat. What are the recommendations with Professor Garbe and the co-workers from 2019? Of course, where we have below 2 millimeter, we have first primary excision, no more than 0.3 centimeter, then followed by secondary excision in order to achieve total surgical margin 1 centimeter together with sentinel lymphatic nodes, of course. And once again, we want to say that the SPECT-CT is one of the best ways in order to localize or best position the sentinel lymphatic nodes. This paper indicates this, and we know that SPECT-CT, the purpose is that with this SPECT-CT we have the possibility to identify significantly more sentinel lymphatic nodes. And after histopathological evaluation and immunohistochemistry, of course, when or if positive, adapt accordingly the subsequent therapeutic approach with immunotherapy or BRAF or MEK inhibitors, so that the patients get a probable survival benefit. That's why we suggest that it is one of the best ways in order to localize the sentinel lymph nodes. It is the SPECT-CT in combination with lymphatic scintigraphy, and then this procedure could be performed. This time we present another case, or the second case from Everett Hospital, or probably this is a very interesting patient with Nevus associated melanoma, again in the scalp area, treated surgically according to the two-stage model of the AGCC and AGC recommendations, where we have used parallel or simultaneously the lymph node scintigraphy and the SPECT-CT. And this combined method was from significant benefit for the exact topographical localization of the lymphatic nodes, their removal, and as already mentioned, the establishment of several more dermatosurgical or oncosurgical units in the capital of Bulgaria, Sofia, but not only, also in other places in Bulgaria. Will have, of course, a positive effect in order to perform this type of surgical intervention. This would create, of course, optimal concurrent conditions for the diagnosis and treatment of patients of cutaneous melanomas, and this could be seen as one step which is more profitable for all patients. Once again, thank you for your attention.